I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is measures that matter. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan.
Hey, Faisel. It's good to be with you again.
How are you doing?
I'm doing great. I'm looking forward to this discussion this evening.
I am too. I'm very excited. Actually, I was just kind of mentioning to you earlier, I had my booster COVID shot on Sunday morning. Earlier this year, I did the Moderna, and on Sunday morning, I had the Pfizer, and I also had my flu shot at the same time. I felt completely fine most of the day Sunday, but then once Sunday night came, oh my gosh, it just completely wore me out, and actually had to call out of work yesterday, which I think was like the first time that I've called out of work on a Monday morning. It was terrible. I felt so guilty to do it, but I'm okay now. I'm up and running, and everything's okay.
Well, I'm glad to hear it, Faisel. All I know is no matter how bad you felt during that vaccine, that was less than you would have felt for the first 30 minutes you were in the ICU. You got COVID and wound up in the ICU.
That's what I was thinking the entire time. I was like, some people are good at being sick. I'm not that person. I'm definitely not that person. I'll go through whatever we got to go to. Well, I'm excited about tonight's topic as well, and with our friend who's joining us tonight. So let's welcome our friend, Dr. Lars Peterson from ABFM. Lars, how are you doing? Welcome.
I'm doing good. How are you, Faisel?
I'm doing well. Doing much better now.
Yeah.
Yeah, definitely doing much better now. And I'm so glad that we can have this topic, discuss this topic for tonight's episode. We had spoken some months back. Yeah, it was some months back about metrics that really matter. We know that there are a lot of metrics that are out there that really frustrate doctors, especially primary care doctors, family doctors, kind of come in the way of the doctor-patient relationship. And so before we get into all of that, for our audience, our audience is a mix of primary care residents, internal medicine, family medicine, doctors in primary care who are interested in learning about models of care outside of fee-for-service, and the direct primary care doctors. So when I think about we know that we're dealing with a healthcare delivery system that's like now almost $4 trillion. And we know that more than a third of the medical care that's delivered in the United States is medically unnecessary. And we know that at least pre-COVID, half of medical care in the country was delivered in the emergency room settings. So it's like we're dealing with a sick system. And if we're dealing with a sick system, we've got to transition to a system that functions better. It would make sense to have metrics that would help us get away from this sick care system to one that's more of a preventive, holistic care system.
I couldn't agree more. Like I'll personally share. I guess I had I see patients. My primary job is at the American Board of Family Medicine as the Vice President of Research, but I still am a practicing family physician at the University of Kentucky in the family medicine residency there. And I had my year-end review with my chair, or the end of academic year review, and I fell short on my quality measures I had to get. And I was like, are you serious? Like because I know I talk to patients about BMI screening, but I felt like apparently that short because I'm not typing in and documenting that I am discussing diet and exercise, which I feel like I do all the time. I just forget to document it. I'm just like, you're just killing me, man. Like, this is like, is this how you really think I'm a good doctor or not? like if I'm like documenting in the right way or somehow forgetting to put things in the chart, which I know it's important, but I'm like, there are other things you could do. And it just, it drives me crazy that people are all about, having to remember, like we switched to Epic back in June to remember to put in the right dot phrase or capture things, or, just rather than like being able to talk to the patient, have a good conversation and not have that burden on. I think I would love to work in that system, and I'm hoping that the work we're doing at the ABFM and the stuff that you're doing will help get us there.
Yeah, what we talk about with the patients, we know that lifestyle, exercise, diet, these are the interventions that can have the greatest impact with any kind of modifiable health outcomes. We know this. I mean, it kind of goes without saying. But yet, if we don't click that we talked about these things, we don't get the credit. When it's just like, actually, it should almost be like you need to opt out. I did not talk about diet and exercise, because we always talk about these things in primary care, especially in family medicine. Family medicine is a relationship-based, way of practicing. It's a holistic way of looking after patients. To think that we're not talking about lifestyle interventions and getting dinged for that, it's just ridiculous.
It's a little ridiculous, but
Yeah, it's a system that we're dealing with. And so, when I think about metrics that really matter, if we were right now, we're in an unsustainable place. Right? We cannot continue to have half of our medical care being delivered in the emergency room setting. Right? We all know this. And actually, I don't know, in Kentucky, do you have standalone emergency rooms propping up?
I haven't noticed any. To be honest, I'm not sure if there are. I know there's a lot. I mean, tons of urgent cares are like proliferating everywhere. And I know hospitals. I mean, I guess I am here to talk. So I'll just tell you, like, I dream, I dream of a world somehow like where you drive around. Like I just drove up on a short trip with my wife today for something, and just driving up and down like through Cincinnati and Columbus, Ohio, like just the huge healthcare systems, like all the hospitals you go by and all the billboards advertising, the robot for your surgery will get you in 4 minutes in the ER to see like a clinician, all these things. I swear, I have never seen a billboard for primary care. Like, to me, like that would be like a sign that we're winning, or like that things are actually shifting, that like relationships matter. Like, our healthcare system X, we have the, primary care physician for you. We will take care of your family. We will meet your needs. Not like we have the best robot, or, everyone loves the robot for surgery, even though it hasn't been shown to really make any difference, but it's a robot because we're fascinated with technology in America. And like, I want the robot, and you're like, well, yeah. And so I do agree that we all know that primary care, I'm assuming you've talked about this on podcasts. I watched a few of them, but on prior times, about that primary care is the only specialty, the more primary care physicians you have, the lower healthcare costs, better quality of care, lower mortality, et cetera. I mean, it's strange that we feel like in at least the research world in primary care, that we've known this for 20 years and it just doesn't move anything. Still stunning to me, but I don't, still working on it.
Well, in Florida and in other parts, especially over here in this part of the country, they have standalone emergency rooms propping up all over the place. And I know the hospitals are able to do this because they know that a big chunk of the care that's delivered in the emergency room you're dealing with patients that didn't have access to primary care, or were coming to the emergency room for primary care service. I mean, that's what they're looking for. These are hemodynamically stable patients that didn't actually have emergencies. So they're propping up these actually standalone emergency rooms all over, and they're billing at the ER rates. Yeah. And so if we needed a transition away, which we do, from the emergency room system to the primary care system, I think that the measures that drive people, like if we had to measure what drives people to the emergency room for their like stable care that could be delivered in the primary care setting, I think one of them would be with trust in the primary care delivery system, not just with the primary care doctor, but it could be with the front desk staff, with your clinical staff, with just the system itself, like relationship-based metrics, not just metrics on A1C not just metrics like the BMI. I mean, these are things that we do that goes without saying.
Yeah, and trust that we'll be there and have, well, not only just trust that your clinician or physician has your best interest in mind and is smart, capable, competent, and like knows what to do medically, but that would be there when you need us, right? And I know a lot of systems. I've worked in a number of those systems. Like I think our patients go to the ER and urgent cares just because they know they can't get in. Like I only do 2 afternoons a week of outpatient primary care, and I have a continuity panel of about 250 patients. But I was in clinic yesterday, and I think my next available appointment is in December. So, I mean, I saw a guy yesterday who I had a cancellation, and he called that morning. He's one of my patients. He's like, "Well, Dr. Peterson's actually available this afternoon." And he's like, "You're kidding me." So, but otherwise, like if you have an urgent issue, you can call the nurse, and you can see, one of our nurse practitioners. Like in our urgent care, or just go somewhere else. But I think really it is us, is that primary care just hasn't kind of dropped the ball on being more available to our patients in order, and how in terms of how we do our scheduling, just the capacity, and that we've allowed kind of these urgent cares that are proliferating and the ERs, like you're talking about, to fill a niche, because we just haven't been able to provide that service, and they don't trust that, when I call my doctor, I can actually get in and see my doctor or, someone on my doctor's team like that day. So it's just easier to go to the ER, and they're open longer, right? You can't see anyone at our clinic, any of the regular people other than the Twilight clinic that they do, outside of 8 to 5. So
I think that's one of the main drivers is that we in the billing model must have that doctor-patient encounter. They don't even call them visits anymore. They're called encounters. Doctors are providers, patients are clients, or whatever you want to call them. They're not even patients anymore. But there's got to be an interaction that has to be in person most of the time. And then there's got to be a billing code attached to it. And we all know that, especially if you're talking about chronic disease management. I mean, I think about how much medical care we were able to provide in residency when we were on call over the telephone without seeing the patient, just having a good story with what's going on. We were able to provide some decent treatment. And then, of course, you see the patient if you have to see him. But right now, the rules are just so rigid with providing patient care. We know that so much of it could be provided, this is not technology. This is everyday life now. My 3-year-old actually just turned 4. Mason's 4 now. So that even for him, if a 4-year-old can use this so effortlessly, this is not technology. I think that many of the people who are making the decisions, though, still view this as technology.
Yeah.
So can I ask a question? So, it's interesting. We have a health system where, $1 out of $3 is being wasted. We're based on RVUs, but I would argue that when you're measuring RVUs, you're not really measuring what matters, because the care that a person gets is more than a sum of the parts. Just like in family medicine, we know the patient is more than just a sum of the organ systems that they have put together. And when you try to break it apart, you lose something. So I would love to hear what you're thinking about how we could truly measure it, that not only shows the value of primary care, but actually would show the value of the care the patient is receiving and the value that the patient's actually getting out of it.
Yeah, I'll start to get into some of that. So the title of the episode is Measures That Matter. And I think a number of people have kind of adopted that mantra, right? That there's, way too many measures, and all the disease specific measures you can get, A1Cs, blood pressure, cholesterol, or you on an aspirin, beta blocker, and just run down the list, medication reconciliation, like hundreds of measures that can all potentially apply to some patients in primary care, but they don't really get at what we do. Like you were talking about, Dr. Dan and Faisel, with relationships. And so, thinking about the core functions of primary care, some work that we've done at the ABFM and also with our research partners at the Robert Graham Center, which is a policy studies wing of the American Academy of Family Physicians. We've done work showing the value of what primary care does. So Barbara Starfield, right? This is what I quiz medical students about after clinic. I don't quiz them about clinical things usually. I quiz them about like, what is primary care, right? The 4 C's of primary care: first contact, comprehensiveness, continuity, coordination. Almost messed that one up, coordination. So, that's what we're doing for patients. We're managing disease, but you're taking care of patients and you're seeing the same patients over time. And so we've done some research using Medicare data, and we're trying to expand it to other populations, showing that, the more a family physician does for their patients, measuring off billing codes. So how many places did you to provide care? Was it outpatient, inpatient, ER, nursing home, et cetera? What kind of procedural care did you provide? Using CPT codes and billing codes. And the more you count those up, so kind of the more you do for a patient, the lower healthcare costs they have. I think as you go from, oh my gosh, I should have read the paper again to get ready for this, but basically the higher you go, the lower the cost. And I think it's somewhere around the neighborhood of a couple hundred. I don't think we got quite to $1,000 per beneficiary per year. So we got evidence that way that the more, if you incentivize family docs to do more, you will actually improve the healthcare system in terms of lower costs. And also, to your point, Faisel, about people going to the hospital and getting care in expensive places, there's actually a lower odds of hospitalization.
Sure.
If your family doctor does more for you, right? Because you're not getting referred out, you can see the same person. And you're getting services in primary care, and hopefully things aren't getting exacerbated because you don't have to wait to go see a specialist. The same person can manage you. And so kind of getting into the continuity core function, we actually have a similar paper using Medicare data as well, showing that when there's a stronger relationship, so you see the same clinician or physician in this case, because you're limited to physicians, kind of over and over, when you go from kind of the bottom, 25% to the top 25% in continuity between patient and physician, I think healthcare costs did go down by about $1,000 per beneficiary per year. And the same thing we found with hospitalizations, like they went lower. So that's, I think, strong evidence that both of those matter, and that measures in healthcare systems should be oriented towards rewarding those. So how much you can see the same person, how much you're doing. And we have been working on those. The ABFM, we have in the research team, but we also have an applied group of what we call the measures team, who are working on, and honestly, they probably think I'm a little dense with this because they've explained this to me about this measurement ecosystem between like the NQF and CMS. And there's a thing called the MUC list, measures under consideration. And you have to get it through like multiple places. And I'm really happy they understand it and love it and like know all those rules. I do not. I know I probably heard them many times. And they're like, we told you this, Peterson. But so they've been working on getting our measures through. And we actually do have the continuity measure. I believe I don't want to misstate this. We're trying to get it through CMS and NQF. So through Medicare and the National Quality Forum. And I believe it got approved by one of those, but I can't remember specifically which ones. I don't want to say.
Okay.
We're working on getting it so you can get paid for it. And then we're doing research right now on comprehensiveness to try to figure out the best way to capture it through claims or through an electronic health record, which the EHR would be faster because claims usually have a delay of a year or two. And then we talked a little a little bit about this in the pre-show. Dr. Dan asked, so in addition to what we can glean from EHR or claims data, there's also what does the patient say, right? The patient voice. It's been very big in medicine and important. Like we are all, became physicians, hopefully to serve patients and help patients. But what do they say? So what does your Medicare data say, and whether or not you build the right thing is how it shows up. So we've been working with, for a number of years now, the Larry A. Green Center, which is based out of Richmond, Virginia at VCU and Case Western, with Becca Etz and Kurt Stange, who created the PCPCM, the Person-Centered Primary Care Measure. That there's a great article kind of describing the psychometrics of it, but it's basically 11 patient-reported items. So just 11 questions, And it's funny, when I first read it, I was kind of like, are you sure these are going to work? Because I remember specifically there was a question like, my doctor and I have been through a lot together. And I was like, oh, come on. But I actually had a patient say that to me after they put that in there once. She's like, because I had a medical student, they're like, oh, yeah, Dr. Peterson and I, we've been through a lot together. And I was like,
wow.
It's like, you're right. I've like been taking care of you for like 7 years. We have been through a lot together. So questions like that, like, so that kind of gets at continuity. The only way you can be through a lot together is to see each other a lot. Questions about comprehensiveness, like, did my practice or my physician or my practice takes care of the majority of my needs? They coordinate my healthcare. My healthcare aligns with my values and preferences, which are always important when we talk about, disease specific measures. Trying to get the A1C down below 7 might not be the best thing for patients, depending on their age and other comorbidities. And I think I also get dinged. I was joking about the .BMI phrase. I think I have one of the lowest statin prescribing rates because I always pull up the Mayo Clinic statin decision tool. When I have the discussion, I show them the dots and say, okay, your absolute risk is 10%, but your absolute risk reduction is only like 2. Do you want to take a pill every day for the next 10 years to be one of 2 people that might have their outcome changed? And they're like, why would I want to do that? And I'm like, okay. Then you don't have to, but I need to figure out how to get them out of my denominator on my quality measures. I feel like I'm delivering better care if I get dinged for it. So maybe I'll stop there. I feel like I've been talking for a while. See if any reactions from you too.
Well,
but it's exciting.
It is exciting, and it's sad also. I mean, it's tragic that patients, when we're trying to influence positive behavior changes, especially when you think about the average American's only 37, 38 years old. So we have a very young patient population. Only 15% of the country is over the age of 65, about 45 million Americans out of 330 million. So the truly medically complex is a small percentage of the population, relatively speaking. So if we're dealing with the younger patients who are mostly healthy, to influence, we can all make better choices. And as a family doctor, the influencer of positive behavior changes, could you imagine if we had a world where we can use the results of the tests or the data to help influence positive behavior change, and we wouldn't have to worry about all the clicking? Because by measuring, like, hey, the more clicks that are in there in the system equates to more touches with the patient or more trust with the patient. It requires the doctor to do all this work that would have been happening if they didn't have to do it anyway.
Yeah, and we're also trying to figure out with like continuity, your point about touches. So like mostly the continuity are things you can bill for, right? Like I build like a note, like I build an E&M service or a procedure, but like you mentioned, like, holding up your cell phone, like, I mean, same thing. Like, so when I call a patient after hours, like that should count as a encounter or a touch, right? In terms of like measuring continuity, your time should be counted the same.
Sure.
We're trying, and yeah, EHRs are, they all work differently now. They counter these things. It'd be best if you just pull it straight from them. But we're trying to think through that about different ways of measuring continuity as well.
So what do you think about risk? I mean, one of the things that I've really enjoyed about working in the full risk environment is nobody cares. I joined ChenMed after spending a good amount of time at an academic center like you're at, and got to be very good at coding. But I started coding for procedures like joint injections and coding for, the higher level visits, because, we still have to put the CPT codes in to communicate with the insurance company. And I had the coders show up and they say, you do know that we're at full risk here. We're not getting paid for any of these codes. And every time you upcode anything, we have to pull the note and review it. And it's actually a waste of our time since we don't get paid for doing that. So quit billing for all this stuff. Just leave it alone. What we're concerned about is can we keep our patients out of the hospital? And so please focus on that and quit focusing on your coding. Don't be spending your time there. And it was like, Oh, that makes so much sense. But I know there's a lot of discussion about how much risks should be taken, because that's what you really want to know is, are you going to keep your patients healthy, or help them live longer or better because of the care you're giving them, and how do we measure that?
Yeah, this gets back to when I first met Faisel. I was working anyway. I was at a National Academy of Medicine workshop on integrating serious illness care into primary care, and it was the very last session of a 2-day workshop about kind of successful models, like kind of where is it now that we've talked about the principles and the ideas and how it could be done. ChenMed was invited, and Faisel specifically, to come and talk about how is it working at ChenMed. And I actually think I ended up on this podcast and talking to you guys because I actually asked him at the end, like after his talk, I was like, wait, I've heard about this ambulatory care nirvana. Like, are you telling me that's what it is? Because I do. And I asked the question, like, well, would this work in a fee-for-service model? And Faisel was like, no, it has to be like capitated. You have to remove this, trying to build piecemeal, et cetera. And I guess I'm not entirely, I don't know. I guess I remain skeptical about that. We'll see the evidence, and I'm going to actually come visit one of the ChenMed offices soon to kind of see, like, boots on the ground, what it's like. So I'm really looking forward to that, and appreciate you arranging that, Faisel. Sorry you can't be there, but it's okay. But I do think there's at least to move, and I don't know if we can get every insurer to move to a fully risk capitated model, because that also, I think, it's easier to do in Medicare because Medicare is more of a captive audience, right? Like once you kind of age into Medicare, you're on Medicare. People don't usually purposely leave Medicare to go to some other insurance product. But like for the working age population to get into full capitation and kind of move the private market that way, I think there'd be a lot to get there. But I mean, a lot of the models they've been doing, and even the National Academy of Medicine put out a primary care consensus study back in May. And one of the big recommendations from that was to kind of move to a more, kind of fee-for-service plus. So kind of preserving a little bit of the fee-for-service system, but also trying to pay for these things you do after hours, like the, returning phone calls, the check-in calls. Like I, try to call patients like in between, like, hey, how were your, how we tweaked your insulin a little bit. Like, how did that work with your blood sugars? Rather than bringing them back for a visit just to ask, how are your blood sugars? It just seems like a waste of energy on both people's side, but yet I don't get paid for that in a traditional system, which seems like a waste because that's creating value, I think, based on some of the, the continuity work and comprehensiveness. And we hope to show with the PCPCM that we've been doing with the Green Center, eventually tying that to claims data to look at costs and hospitalizations and the other things that the ChenMed model has been doing. So yeah, I think we're working on it. Research is slow, unfortunately. Sometimes you wish you could do it faster.
I'd like to get into the trust.
Yeah.
What allows the trust, and what that does with patient behavior. But before we do that, I'd like to take a quick 20-second commercial break, and then we'll come back. We'll talk about trust and building trust with patients, especially with the after hours, and then get some closing thoughts from Lars. We're already almost at time.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. It was only 20 seconds. With trust, Lars, one of the things that we think about, what we hear from patients over and over again, and even many of the care team, many of the members of our care team, how we build trust, it's actually with the little things. That little text message, when there's that gray zone, how we respond to patients who show up unscheduled. So I'll just share you, language matters in the world outside of the transactional system. When you have a relationship-based system, like for example, a patient that shows up unscheduled, we don't call them walk-ins. We call them patients in need. And we actually have patients in need protocols in place because it's a different reaction. The typical primary care setting, a patient shows up unscheduled and the front desk staff walks back saying, "Oh, I've got to walk in." And everyone's eyes kind of roll. "Oh, this is an inconvenience to our day. We've had all these stable maintenance visits, and now you've got this patient who's in need of medical attention, ruining our scheduled day." And so we call them patients in need. And the patients feel the difference. The front desk staff come back and they say, "Hey, we've got a patient in need." And actually, most of us went into medical EV. If you're looking at physicians or you're looking at nurses, we became doctors and nurses to look after patients in their times of need. And the way that we respond as a primary care delivery system to patients in need is what builds the trust and the confidence in the primary care delivery system. Because otherwise, nobody wants to go see a random doctor in a lab coat. They'd rather go to the doctor or the care delivery system that knows them best. And you build trust with the little things, even like a little text message after hours. "Hey, doc, hey, I've got this going on." And the doctor's ability to respond back quickly. That's what drives the trust. So I really stand by that. If we have to worry about billing for every interaction, if we have to worry about clicking for every influence, every type of basis of influence, it takes away from the doctor-patient relationship. I mean, we can use this can be a powerful extension of the doctor-patient relationship. And actually, we've seen that with COVID. We had to switch from more than 90% in-person visits to more than 90% virtual when the pandemic first started. Right now, I think it's about a third of our visits are done in this virtual manner. Some of the centers, it's the 10 to 20%. It depends on the center and what's going on with each individual patient. But this can be an extension of the doctor-patient relationship. It doesn't need to be a barrier to it.
Yeah. I like that framing of language about the patient in need rather than the walk-in. But yeah, I mean, I think it does get back to the trust because I know there are people who are working on developing measures of trust, kind of like patient, like I mentioned, the PCPCM, but also they're looking at patient-reported measures of trust and hope. Kind of like, do patients have hope that they'll get better and that the system will work out for them, as opposed to just feeling like, sometimes physicians feel like we're a cog in a wheel. And I don't know if you've done a whole thing on burnout yet, but yeah, there's a lot of physicians who feel like they're just a cog in a wheel, and patients feel like they're just in a system that doesn't care or just wants to, get them out, essentially, like get them in and out and kind of go through the churn rather than like address what's going on with them and feel like their voice is being heard. So I think, definitely be a better system on both ends for physicians and patients and nurses. Yeah. Yeah, and hope and trust. I think I agree with everything you said about like can we be there? Can we take care of you? And some of those little touches. One of the strangest things that happened to me in medicine the last couple of years is I had a patient who I'd taken care of for like 5 or 6 years, and I also saw her, her wife. And then well, they're both my patients, but the one I saw far more frequently than the other one. So the one who came in frequently, just, I can't remember what actually ended up killing her, if it was a heart attack or a dissection or something, but she had like an acute event, and I just like got a notice, like, the ER notice. It's like, "Oh, your patient died." And you're like, "What the hell?" Like, it was like, shit. So I ended up calling, the wife, who's also my patient, and, to say like, "Hey, I'm so sorry this happened." And like, we had a nice heart to heart and kind of shared memories of her and everything. And like, at one point she told me, she's like, "Well, I'm just so glad you called. I didn't think doctors called patients anymore about stuff like this." And I'm like, "Are you kidding me? Like really? Like, that's just, said so much about kind of like, to your point, like, are people losing trust and hope in the healthcare system? Like, to the point where you wouldn't expect the doctor who takes care of you and your spouse to not call you when your spouse dies, like the patient dies." This was really like, wow. Like, I didn't think I was doing anything special, like, at all. I thought I was doing like, like,
sure,
what you should do. And so I think how we can get those things, like, I didn't get a bonus for that. Like, that didn't come up in my, to get back to the beginning of the whole thing about I fell short on my quality measures because I was this short of the BMI. Like, I didn't get bonus points because I called my patients, families when they've passed, or died. It's just a little kind of, getting the whole point of this about that we're kind of looking at the wrong things sometimes and rewarding the wrong behaviors. And that, I think, sets the expectations of what patients sometimes think of us. Like, they come in and all we're perseverating on is your numbers. Like, where's your cholesterol? Did you take your pill? What's your A1C? As opposed to, how are you doing? How is your life? How are things going for you? Are you meeting your goals? Are you doing what you want to do with your health? So, yeah.
Thank you for sharing that. Thank you for sharing that story, Lars. If you think about it, if we have 5,000 years of written history, there were only ever two sacred relationships: the relationship that humanity had with the clergy and the relationship that humanity had with the healers. There are two sacred relationships. And unfortunately, in the United States, the doctor-patient relationship is no longer a sacred relationship. It is too much of a transactional relationship. And up until probably 150, 200 years ago, the most critical purpose that a physician had was to help ease the transition from this life to the next life for both the patient and the patient's family. Well, thank you for sharing that story.
You're welcome.
Well, thank you for joining us tonight, Lars. And Dr. Dan, what a great conversation.
Absolutely. This is just hopefully the first of many conversations about how to highlight the importance of the doctor-patient relationship in primary care.
Yes, but we must change the language as well. The language sounds too transactional. And I think that we need to bring back some of the sacred terminology. Let's bring back some more of the relationship so that doctors and patients are rewarded for when they achieve better health rather than generating more RVUs. To our audience, thank you so much for joining us this evening. For more information about tonight's topic and to explore career opportunities with ChenMed, please visit chenmed.com. I'd like to share another point with you. We're on track to open another 500 centers over the next 4 to 5 years. A year and a half ago, we had crossed 2,000 employees. It was a big deal. We're very excited. I just found out that 2 weeks ago, we just crossed the 4,000 employee mark. It's a very exciting time. We are leading a primary care revolution. We believe the doctor-patient relationship is sacred. If you'd like to learn more, please visit chenmed.com. We believe access to primary care is a right, not a privilege.